Real life.
A
Devasis, please.
a very good evening to all our members, those who have connected right now. I'd like to invite everybody for this ophthalmology residence teaching series number 41. With the number 41, I think you can really guess over the years how many long it is going on. Today's topic is excellent myasthenia gravis. We need to know what are the recent developments in the myasthenia gravis, particularly for the young residents. With this, I thank my energetic team of President Dr. Jennifer and CSC Dr. Nitin. I'd like to thank our Chief Coordinator Dr. BNR Subudhi and our mentor Dr. Ajit Babu Majji, who has been continuing this over the years, as well as the coordinator Dr. Sabyasachi Patnaik. I welcome Dr. Himalini Samant, the director of the Accuresight Eye Center from Mumbai. The moderation will be done by none other than the dynamic Dr. Rajesh Majumdar Chaudhary. We have a galaxy of panelists in the form of Dr. Vivek Warkat, Dr. Sudhir Kumar, Dr. Rahul Prasad, Dr. Dipankar Das, and Dr. Balakrishna Samantarai. We have a very young and dynamic set of discussions today. I think it will be a fruitful discussion on myasthenia gravis. With this, I hand over the session to Dr. BNR Subudhi, sir. Welcome, sir.
Thank you, Dr. Devasis. So before I start, I will ask our president to say a few words. Ma'am, Jennifer, madam.
Okay, yes, thank you. Good evening, everyone. A very warm welcome to this 41 session of the EIZOC Ophthalmology Resident Teaching Series. ORTS has grown into a strong academic platform that reflects EIZOC's commitment to structural learning and resident focused teaching. And in a rapidly evolving specialty like ours, such forums are vital in bridging the theory with practical decision making. I would like to place on record my appreciation to our speaker, Dr. Himalini Samant, our esteemed panelists and discussants for their time and their valuable contributions. My sincere appreciation goes to our Dr. Ajit Babu. And also, I would like to put forward my appreciation to both the coordinators, Dr. BNR Subudi and Dr. Sabyasachi Patnaik, for their dedicated efforts to ORTS, which is a flagship program of EIZOC. I also thank and welcome our moderator, Dr. Rajesh M. Chaudhary, who will skillfully steer the discussion and keep the session engaging. And I appreciate our residents for their enthusiasm and curiosity, and encourage them to make full use of the discussions during the session. I wish everyone a highly enriching and academically rewarding session.
Lost connection.
You continue, no?
Yeah. I did. Thank you, ma'am, for your kind introduction. I will ask our CSC Nitin, Dr. Nitin, to say a few words. Dr. Nitin?
Yeah.
There.
Yeah, please.
I welcome everyone. Thank you very much. And we all know that this program is actually intended for resident of this EIZOC states, and the topic are well chosen by none other than Dr. Ajit Babu Majji sir and Dr. BNR sir. So I will request all the residents. This is indeed a sheer opportunity to all of you to listen to the people, those who have lived away with the kind of diseases and the kind of conditions. So this is indeed a great opportunity to learn. I'll request you to kindly discuss, and whatever doubts you are having, a panel of discussants are there, a panel of senior consultants are there, those who can give you much valuable points which you will not find probably or will be difficult to get from the books. So the learning will of course be for everyone, those who will listen, but this program is basically designed in a way to keeping in mind the resident and the benefit of resident. So with all this, I'll hand over again back to BNR sir.
Thank you, Dr. Nitin. I once again I welcome you all to the EIZOC ORTS session number 41. And today's speaker has already been told by my President and Secretary, Dr. Himalini Samant, and she will be speaking a topic, very interesting topic, that Myasthenia Gravis. And as you know, every time we select a good topic, and this time we are continuing with the neuro-ophthalmology topics, and this is our ORTS platform, is one of the wonderful platform from EIZOC state, for not only for the EIZOC states but also all over the country. We invite guests from all over the country, and also sometimes we get the postgraduates interested for this program from outside also. And it's a really interesting session, and today's session definitely will be very much interesting. And I thank our EIZOC team, Dr. Jennifer Madam, Dr. Devasis, and Dr. Nitin, for supporting this program since the last few years. And definitely our mentor plays a major role in this program. And as you know, it is actually a teaching program for the postgraduate residents, and direct interaction between the speakers, panelists with the residents. And he always chooses good topics and good speakers. And I thank him for mentoring this program since last few years. And of course, the credit goes to my co-coordinator, Dr. Sabashach Patnaik, who both of us devised this program during the Corona time. And since then we are continuing this program. And of course, today's speaker is none other than dynamic Dr. Himalini Samant. She is the director at the Agura Eye Center, Mumbai, and she will be introduced by our moderator. And today's moderator is again Dr. Rajesh M. Chaudhary. He is a wonderful surgeon based at West Bengal, and he's a practitioner. No doubt he has worked most of the time in Sankarnathala, Calcutta, and he has come to our platform many times. I welcome him to this program to moderate this session. And today's panelist, Dr. Vivek Wakar, is a consultant and head Mariam Hemant Children's Eye Care Center, Child Set Institute, LV Prasad Eye Institute, Bhubaneswar. Dr. Sudhir Kumar, Professor and Head, Government Medical College, Betia, Patna, Bihar. Dr. Rahul Prasad is the Additional Professor, Cataract and Retina Services, RIO, RIMS, Ranchi. And Dr. Dipankar Das is the HOD and Senior Consultant, Department of Ocular Pathology, Uveitis, Neuro-Ophthalmology Services, SSM, Guwahati, Assam. And Dr. Balkrishna Samastraya is our Associate Professor at Desi Medical College, Cuttack. So these are our panelists, and of course the residents who will be participating in this webinar are many from different parts of the country. Dr. Vasavi Karutaparthi from LVPI Visakhapatnam, Dr. A. Lasya from AIMS Bhubaneswar, Dr. Chandan Dixit from High-Tech Medical College Rourkela, and Dr. Sanjana Sahu from High-Tech Medical College Bhubaneswar, Dr. Subhasri Mishra from RIO SC Medical College Cuttack, Dr. Snehasis Gupta from Rourkela Government Hospital, Dr. Priyanka Agrawal from Ruby Eye Hospital Berhampur, Dr. Indrani Chanakya from MGMC Jamshedpur Jharkhand, Dr. Asmita Gope from RIO West Bengal, and Dr. Rakhi Yadav from SSM Guwahati. So these are the residents. I will request our speaker today to, in between the talks, put some questions to these residents by their name, not anyone. So if you ask by name, they answer the questions. So with these few words, I welcome you all the viewers behind the screen, to this another session of ORTS program. Thank you, everybody. Now I hand over the mic to our moderators today, Dr. Rajesh M. Chaudhary. It's over to Dr. Rajesh Choudhury.
Thank you. Can you hear me?
Yeah, we can.
Okay.
Okay. I'm traveling, so that's a problem actually. But anyway, before I start, I must say that I'm really envious of today's trainees, because during our time, we never had fabulous mentors like Dr. Subudhi and Dr. Patnaik, who in their, wisdom had devised such a fabulous way of spreading knowledge. I mean, really, hats off to both of you, and, I'm so jealous. But without much ado, let's start with this program today. A very important topic, both for examination purpose and also in our day-to-day comprehensive practice. So to steer us through this very interesting topic, we have Dr. Himalini Samant, who is an eye surgeon of real repute. She pursued her specialization in pediatrics and neuro-ophthalmology from Shankar Netralaya, Chennai, and that's where she developed this skill, this thirst for knowledge, especially for neuro-ophthalmic issues. She has also worked as an associate consultant in the Department of Pediatrics and Neuro-Ophthalmology at Shankar Netralaya, Chennai for a long time. And then she moved base and she started working as the Grant Medical College, JJ Hospital, for the previous 15 years as a professor. Now she's the director at the Acura Eyesight Center, Mumbai, and she's currently also the president of the Bombay Ophthalmology Association. Dr. Himalini Samant is known for her skillful dealings with patients, and she has a reputation which has spread far beyond the limits of Maharashtra and India. I give you, ladies and gentlemen, Dr. Himalini Samant. Dr. Samant, welcome here. And, so we are privileged to have you with us. The floor is yours.
Thank you, sir. And thank you, Dr. Rajesh, for your kind words. I'll be sharing my screen now. Okay, everybody can see my screen, right?
Yes.
Okay. So I'm going to start with what are the student goals. So what am I going to discuss and what as a student you should know about about this topic. So ocular myasthenia gravis is a disease of the neuromuscular junction. It is shared not only by us, but even these patients go to the neurologist. So either they will come to you first or they'll go to the neurologist first. What as a student you need to know about myasthenia gravis? So you need to identify these cases clinically and do an appropriate workup. The commonest case presentation that's going to come to you in your OPD is going to be patients with acquired ptosis. The management part, you don't really need to know too much because usually the management is taken over by the neurologist. From the exam point of view, what do you need to know? You need to understand what the disease is in terms of pathogenesis, recognizing the clinical signs, performing the relevant tests, electrophysiology tests and its significance, and knowing what the antibodies are, and treatment you should know in very brief. So with that, we'll go on to the next slide. Okay. So first is, what are the antibodies? So first I'm going to give you a general introduction about myasthenia gravis and then we can take up some cases. So what are the various antibodies which are involved in myasthenia gravis? So the first one is called as AChR. The full form is acetylcholine receptor antibody, and this is the commonest. The second one is called as MuSK antibodies. The full form is muscle specific kinase antibodies. It is less common. It is more positive in those patients who present with either a facial weakness or respiratory difficulties or neck weakness. The third uncommon antibody is called as the low density lipoprotein related protein 4 antibody. So in the Viva, you can be asked that which are the 3 antibodies which are associated with myasthenia. So here you go. Now, how do you identify these antibodies? You have to do a simple blood test. There is no fasting required for this blood test, and the result usually takes about 2 or 3 days to come. A positive AChR or a positive MuSK test tells you that your disease is myasthenia gravis, and then you can refer this patient to the neurologist and they can start the treatment. So what is a pathogenesis? This simple diagram I have made. So we all know that the disease is a neuromuscular junction disease. And for a normal reaction to take place at the NM junction, you have acetylcholine, which is released. The acetylcholine goes and binds with the acetylcholine receptors, and a normal transmission happens. But in myasthenia gravis, there are these antibodies. These antibodies go and bind with the acetylcholine receptors and thereby destroying them. And hence, less of these receptors are available for the acetylcholine to bind with them, and therefore the disease happens. When, as a student, when should you suspect that this patient of acquired ptosis could be having ocular myasthenia gravis? So you should be suspicious of ocular myasthenia gravis in all patients with acquired ptosis with or without double vision. Ocular myasthenia gravis should be considered as a differential diagnosis in any patients who complain of diplopia and present with oculomotor weakness without pupillary involvement. Any oculomotor weakness with variable measurements or shifting palsies, that means once you see the patient presents looks like a third nerve, on after about a week you see the patient has presenting with abduction limitation, so it's variable. So when that happens, you should suspect that could this patient be having a myasthenia gravis. But what are the red flags which tell you that this is not a myasthenia gravis? If there is involvement of the pupil, if the patient complains of diplopia with eye pain, if diplopia, ptosis with headache, visual loss is associated with the acquired ptosis, if there is involvement of the trigeminal nerve with loss of corneal sensation, then this acquired ptosis is not a case of myasthenia gravis. So if you see any of these symptoms, it's not myasthenia gravis. So then how do we establish the diagnosis? So there are some clinical tests and signs which tell you that, okay, this looks like a myasthenia gravis. So this is the fatigue test, the eyes test, and then you have some classic signs. What are the lab tests that will support you in your diagnosis? So you have to measure the antibody titer, which we just discussed. And then what are the electrophysiological tests that we need to know? One is the RNS test and the other is the single fiber EMG. So now I'm just going to show you a video of the fatigue test. So this is a child who presented with a left-sided ptosis. I'm asking the patient to look up. And then if you slowly see, the left eye is gradually drooping. And it's drooping even more. Okay. So it's drooping. And a little bit of the right eye is also drooping. All I'm asking the patient to do is look up. So sometimes it's difficult to have the child look up.
Very good.
Now trying to do make him tired by looking up and down, and then once again seeing the fatigue. And you see that he's holding and using his frontalis muscle to try and keep the eye open. So this is your fatigue test.
Okay.
This is another video of a fatigue test where the child had presented again with a left-sided ptosis. Ask the patient to look up and down. And you see the patient. And you see that the left eye ptosis, and along with that, you see this right eye is also drooping a little bit. So again, this is a classic positive fatigue test. So this is, I told you about the clinical signs. So there are many, but I have a video of the seesaw sign. So this patient had presented again with the left side ptosis. You raise the ptotic lid and you see that the right eyelid is drooping. This is your classic seesaw sign. Okay. Next, we come to the eyes test. So I've told you that there were some clinical signs. Now we are doing some tests in the OPD which can tell you that, okay, this patient surely has myasthenia. So this is the eyes test. So how do you do the eyes test? You ask a patient with acquired ptosis to close the eyes, keep the ice pack on the lid, on the ptotic lid for about 2 to 5 minutes. A positive test is when the ptosis improves. The cooling, what is the reasoning behind this ice test is that the cooling reduces the breakdown of the acetylcholine, and therefore more acetylcholine is available at the neuromuscular junction to carry out the transmission. So ice test is positive if the ptosis improves. It is 80 to 90% sensitive, so it's a very useful test in the OPD. And it is useful when the patient presents with ptosis. So for example, you have ocular myasthenia gravis patients who presents with diplopia. In those patients, who only present with diplopia without the ptosis, it's difficult to elicit and perform the ICE test. But in those who present with ptosis, it's a very good test. So I'll show you a patient. This is a child who had a left-sided ptosis. And when you do the ICE test, I've used this kind of an ice pack. I've applied it on both the eyes. And then after 2 to 5 minutes, the ptosis has improved. So this is a positive test and tells me that yes, this child has myasthenia gravis and requires more investigations. Now, knowing your electrophysiological tests. So which are the electrophysiological tests I mentioned? One is the RNS study and the second is a single fiber AMG. So what is this RNS study? Repeated nerve stimulation. It's a very sensitive test. Who is it performed by? An electrophysiologist. That means we don't do it. How is the test performed? You give an electric stimulus to a motor nerve. The muscle response is recorded in a graph form. You compare the first response with the fourth or the fifth response. In a myasthenia, a decrease or a decremental response is seen. So if you find a difference of more than 10% between the first response and the fourth or the fifth response, the test is called positive test. Which are the nerves commonly tested? So the nerves which are commonly tested are your ulnar nerve, your facial nerve, and your axillary nerve. Sometimes your antibody titers are negative, but your RNS studies may be still positive. In that case, the patient may still be having a seronegative myasthenia gravis. What is a single fiber EMG? The single fiber EMG is a little bit more sensitive than the repeated nerve stimulation study. So what does this measure? That is measuring, RNS is measuring the nerve. What is this measuring? It is measuring the muscle jitter. So variation in timing between two individual muscle fibers is what it is measuring. So it detects very subtle transmission problems, and the common muscle tested are the orbicularis oculi and the frontalis. So I'll take a little break here. Has everyone understood? Any questions? Any questions to the panelists? Anybody? Okay, I'll go on.
Good evening, doctor.
Yeah.
I'm Basvi. I have one question. Like in patients who are like don't have ptosis and presents with only ocular limitations, can we do the eyes test and measure the how much limitation is improved after
Yeah.
keep
You
eyes?
can, Vasavi, you can. But in that case, then what happens is that you have to measure with prisms how much squint is having. And then you do the eyes test. And then post eyes test, you measure how much squint is having. So if the squint is decreased, if the measurements are showing a decrease, then yes, it's an eye test. Theoretically, it's very easy to say, yes, we can do it. But practically, it is a little difficult. Vivek, you have any comments?
Yeah, I agree what Dr. Himalini just now said. Usually we don't do, when there is a extraocular muscle involvement in OMG, this test has a very high sensitivity in terms of, the ptosis alone. Although you can guess, but most of the time, if you see, they'll have the combined presentation. So I think this is useful, especially for ptotic leads.
Anything else? Anybody else? Okay. So I'll go on. Eye signs in ocular myasthenia gravis. So again, this can come as a short note. This can come as viva question. Kansky has a lot more signs. I've mentioned only about 3 signs. Kogan's lid twitch sign, a seesaw ptosis, the video I showed you, and a peak sign. So if you see any of these signs, if you see a patient, you try and demonstrate these signs. If you see these are there, then probably the patient is clinically looking like a myasthenia patient. Neostigmin test. Again, it's a theoretical test. I don't perform it in my OPD anymore. Neostigmin test is performed by giving a little injection atropine 20 minutes prior to the test. After doing that, you can inject neostigmin. So neostigmin and tensilon test are same, but tensilon is not available in India. Neostigmin is, but I don't usually perform this test. So you can inject neostigmin. This is the dose that is given, 0.04 milligrams per kg body weight. It is given intramuscularly. This is a patient who was injected with the ptosis, and post-ptosis, he looks like as if he's completely normal. There's an improvement in the ptosis. So again, this test is very helpful if the patient has just presented with a ptosis, but difficult to elicit a positive test when the patient has presented with just ptosis, with just ocular muscle weakness without ptosis. In that case, again, you'll have to measure the squint. I don't usually perform this test in my OPD any longer. Any of the panelists or discussants, do you all do this test? Vivek?
Yeah, I do perform, this particular test because see, the ocular myasthenia is an autoimmune disease, and then this is the disease for rest of the life. So before I label it as, something like OMG, I do perform most of the test as much as possible so that if one of them is positive, basically if you look at the specificity, it is a cumulative specificity of multiple tests. And many times when you come across, these tests are, I mean, the serum antibodies, they are negative, then sometime we have to rely on these particular tests. So that helps us to even define, whether it is a seronegative and positive. Because, at the end of day, OMG is one of the most masquerading disease in terms of, the other ocular diseases, may it be a cranial nerve palsies, or may it be, like other non-specific ocular motility disorders like supranuclear gaze palsies, INO, unilateral, bilateral. So in those situations, I think we ultimately has to think about the OMG. So in that context, I think I usually prefer to do as much test as possible. And obviously it depends upon, like
So
we
there is a little difference of opinion. Like I'm in private practice. I don't do this.
exactly, I was
In
about
medical
to come to
college,
that.
yeah.
So we do have
I have a I
additional
have
practice
a
where we
I
have
have a reservation. I have a
anesthesia.
reservation because no, in systemic myasthenia, both adrophonium, which is not available in the country, and neostigmine is much more positive comparative to ocular myasthenia, where the it is usually less positive in those cases. I will take the clinical test as well as the whatever even the fiber EMG will give a better indication along with the antibody test.
Okay, so as a student, from exam point of view, whether you do this test or no in your future practice, that is okay, but you need to know what this test is. Okay, so as a student, you need to know the test. Now, what is the management of ocular myasthenia? Like I told you, that management part is usually managed by a neurologist. So as an ophthalmologist, you need to know what the management is, but you don't need to really know the details and the dosaging and all of that. So you have to explain to the patient that if the patient has presented with an ocular myasthenia gravis, there's a good possibility that he's going to progress to a generalized myasthenia gravis. Anticholine esterase inhibitors. So what is anticholine esterase? I told you acetylcholine is released. Anticholine esterase is an enzyme which destroys the acetylcholine. So by giving the anticholine esterase inhibitors, you're making more acetylcholine available for it to work on the neuromuscular junction. What is the generic name of this acetylcholine esterase inhibitor? It is called as pyridostigmine or neostigmine. What is the brand name? The brand name is Mastine or Distinon. You usually start the patient on this anticholine esterase inhibitors. And then once they have taken that for about 15 days, 20 days, 1 month, then you gradually introduce a small dose of steroid in it. Those cases who don't respond, you can try some immunosuppressants. Sometimes in some cases, you may even do a plasmapheresis. And thymectomy again is important because in all patients of myasthenia gravis, when you have your antibody test positive, when your RNS study, single fiber, all that is positive, in your workup, you have to include a CT scan of the chest. Why do you have to do that? To rule out a thymoma. Why do you have to rule out a thymoma? Because thymoma is associated in most autoimmune diseases because that is where your antibodies are being produced from. So hence a CT scan of the chest has to be done. And if you find a thymoma in a patient with myasthenia, then usually a thymectomy is performed. So with this background, I'm going to discuss a few clinical cases. They're not very typical cases, and all of them have different presentations with a good take-home message. So let's start with the first case. This is a 35-year-old lady who had complained of right-sided drooping, as you see in this picture. 1 second. As you see in this picture. So she did not complain of any diplopia, and the ocular examination otherwise was normal, except that she did have a little elevation deficit in the right eye, and the ptosis to me seemed fatigable. So this is a picture showing the elevation in adduction as well as elevation in abduction, slightly limited as compared to the left eye. But her main complaint was right-sided ptosis. So now the question for the students, what will you do next? So, and what is your differential diagnosis? So how would I approach this test? What the diagnosis?
Only let them answer, no?
Okay. What would you do? The patient has presented with a ptosis and difficulty of elevation in adduction and abduction. You can answer wrong also, it's okay.
Yeah, we can only answer wrong. That is better actually.
This arrow is not visible.
By name. Ask somebody by name, then they will answer.
Snehashish, can you tell me what you would do in such a patient? You are sitting in the OPD. This patient has come. She's saying right eye sudden onset drooping. She's only 35 years old. She doesn't have any diplopia, but she has an acquired ptosis. And I'm telling you that it's probably fatigable. And there is elevation deficit in adduction as well as abduction. You think it's a third nerve?
Ma'am, first I would like to evaluate the ptosis.
Okay.
What is the amount of ptosis, whether it's mild, moderate?
Okay, so ask me the questions. I'm telling you it's moderate ptosis.
Okay, ma'am.
Next question. What else will you do? First, tell me what do you think? What is your differential diagnosis? Like this presentation, does she look like an incomplete third nerve? Does she look like a monocular elevation deficit? What does she look like? Anybody else wants to answer? Indrani, you want to try? It's all right to be wrong. There's no problem.
Yeah, because this
It looks like monoocular elevation deficit of right eye.
Correct. So if you see this kind of a patient, I've told you, I've given you a little background of a myasthenia gravis. So what is the next test that you would like to do in the OPD? She has acquired ptosis.
The ice pack test.
Very good. The ice pack test. So that's exactly what I did. So this was running in my mind, okay, that the diagnosis looked like she had an acquired monocular elevation deficit with ptosis. So my first differential was that could this be a myasthenia? My second differential was maybe a supranuclear cause. Is she presenting with a partial third nerve palsy? But it didn't look very likely like a partial third nerve palsy because the ptosis was fatigable. But before I sent the patient for neuro imaging, a simple test in the OPD was performed, which you rightly said was the ICE test. And the moment we did the ICE test, you see that the ptosis has completely recovered. So then this patient, what workup we did? We did an antibody workup, we did EMG, we did the RNS studies and the CT scan chest to rule out thymoma. So the take-home message was that ICE test is a simple and inexpensive test and saved this patient from undergoing neuroimaging. Okay? We'll go to the second case. So Indrani, get ready. This is your case, huh? 24-year-old male, all right, complains of sudden onset diplopia, which is followed by ptosis, which is progressively increasing. The general health of this patient is very good. Ocular examination is very good. Vision is 6/6 and anterior segment fundus all normal. The pupils were also normally reacting. Now, if you take a look at this patient, can you describe this picture? This picture, can you just describe what is happening in the right eye? I've written it, but you can describe it.
Yeah, right eye ptosis and exotropia.
There is an exotropia. So if you see this patient and there is a little adduction limitation here, okay, what do you think this is? And he's a young patient. I've already written here. What is your first look?
Third nerve.
Incomplete third nerve. Okay. But now tell me something. The elevation is normal. The depression seems normal. Can a third nerve only present with adduction limitation and just the ptosis? Does it seem likely? And if yes, then where do you think the lesion is? The third nerve, you know, has a superior division, has the inferior division, right?
Yes.
The superior division, apart from supplying the levator, supplies other muscles also. Correct? So why selectively only the medial rectus is affected and not the other muscles? That is a question that has to go on in your mind. Plus, this is a young patient. Correct?
Yes. Good.
So any test that you would like to do? Can we do an eyes test in this patient?
Yeah. Size test.
We can, because remember I told you that it is a very sensitive test when you see ptosis. Can we also do a fatigue test for this patient?
Yes.
Yes, so we can do a fatigue test. So that's what we did. The approach, what my thinking, then this is how your thinking should be, that look, it looks like a partial incomplete pupil sparing third nerve. Sometimes you have an evolving third nerve and he's a young patient. Should I neuroimage this partial third nerve irrespective of the pupil? That is our general teaching, that if you see something that looks like a third nerve, it is an emergency. You would definitely want to neuroimage. Do an MRI with contrast would be an ideal choice, and maybe even go ahead with an MRI angio. This is what I would do if my fatigue and eyes test would have been negative. Okay. So first inexpensive test before I send the patient for neuroimaging. So this is what I did. We did the fatigue test. This is the primary gaze of the patient. We did the fatigue test. So what has happened to the ptosis? What has happened to the ptosis?
Worsen.
It has worsened. And then when we did the eyes test, what has happened to the eyes and the ptosis?
Improves.
Improves. So your diagnosis was myasthenia gravis. Understand? See the thinking process. So in this patient also, suppose if these two tests were negative and I would have done the antibody titer and that also would have been negative, then probably I would have definitely neuroimaged this patient. But before I send for neuroimaging, there are two simple tests that each student can do in the OPD, which is your fatigue test and the eyes test. So the idea is to emphasize how valuable these tests are in the OPD. Okay? We'll go on to the next case. And who is going to take over this case? Let's see. I have the pictures here of y'all. Sorry, Sweetie is there?
Sweetie.
Sanjana Sahu, Sweetie.
Yes,
Okay.
ma'am.
Who's Sweetie? Have you switched on?
No, yes, ma'am, I have switched on.
Okay, this is your patient. Okay. So the 75-year-old, he's an old man. He complains of vertical constant double vision. Okay. What do you see in myasthenia? In myasthenia, you don't see a constant double vision. You see a variable double vision. But this fellow said constant double vision. His left eye looked a bit smaller. That's what he said. He also complained that I have some instability in walking. And this patient was treated as an ischemic palsy. He was said wait and watch approach because the MRI was normal. Okay, so let's see what he has to say here. Good morning, uncle.
Yeah,
What exactly is your problem?
I have got a double vision. It's a vertical vision.
Since when?
Since about, it started before 6 months. About 6 months.
You feel it has
Yeah.
increased in this 6 months?
Yeah,
It
yeah.
has got better?
No, it is increased in the 6 months.
Okay. Any other problems you have?
Yeah, by walking, I don't exact my position is not well maintained.
Okay. Do you feel your left eye is a little smaller than the
Yeah.
right eye?
Yeah, my
Since-
left eye is solar.
Since when you noticed that?
Since it is about also 6 months.
Okay. Did the eye become small first or the double vision and this came
No,
together?
I become small first, then the double vision.
Okay, so see very clearly he's saying that he feels that his left eye is small. So what he was
Yes.
describing as a little ptosis. He said that this was followed by the double vision. He also has some instability walking, and he was told that he has some ischemic palsy, wait and watch, because he was already neuroimaged and the neuroimaging was normal. Okay.
Okay.
So now
Ma'am,
let's go. One second. Sorry.
ma'am, is this a case of generalized myasthenia gravis?
So let's see. Let's come to that. So the ocular examination was normal and the vision was 6/6. Okay. And let's see what the cover test was. The cover test, I got a right vertical R/L in the primary gaze. That means I got a right hypertropia in the primary gaze. And after that, it increased in the left gaze. It worsened on the right head tilt. which meant that the patient had a superior oblique palsy. So let's see the 3-step test. See very carefully. R is right eye is coming up, down, left eye going up.
RTP.
Right eye coming down, left going up.
RTP.
Right eye coming up, coming down and left eye going up. Okay, so you check in the primary gaze, you check in the right and the left gaze, and you check in the right head tilt and the left head tilt. So there was right hypertropia in the primary gaze, which increased in the left gaze, which worsened on the right head tilt, suggestive that this patient had a right-sided superior oblique palsy. Now you tell me, doctor, that if you have a right-sided superior oblique palsy, which is not improving. So first of all, what is your approach to a superior oblique palsy? Would you neuroimage this patient?
Ma'am, the MRI has been done now of the patient.
Yes, MRI has been done. The MRI is normal. But if the patient would have come to you for the first time, would you neuroimage this patient?
Yes, ma'am.
Tell me why? Why would you neuroimage this patient? You're right. I will also neuroimage this patient, but why? Okay, see, the patient has come with a superior oblique palsy. He's an old man. He has other systemic health conditions. So,
Yes, ma'am.
when you do a cover test and you find that the patient has a superior oblique palsy, it's normal, no? It's natural for any one of us to think that this is probably an ischemic palsy.
Yes,
But you
ma'am.
see, what should alert you is that this ischemic palsy, do ischemic palsies improve or worsen over time?
Worsen.
Ischemic palsies improve.
No, improve.
Oh, okay.
Okay, all ischemic. Ischemic palsies means blood supply is less. All ischemic palsies improve on their own with time. But if you come across a patient where the ischemic palsy is not improving, but the patient's symptoms are worsening. So he's saying that my symptoms are not getting better, I'm feeling worse. It is at that point that you have to think of an alternate diagnosis. Okay? So we waited for about 3 to 4 months, his symptoms worsened, and hence I thought that, okay, could this patient be having myasthenia? Based on that hunch, we got a ACHR test, which was strongly positive, 7.8. So MRI was normal, ACHR was strongly positive. This was a patient who presented with a superior oblique palsy. This is an uncommon presentation of superior oblique palsy. The take-home message in this case is that any diplopia that is not getting better requires further evaluation. Variability is the key feature described in myasthenia gravis, but not all cases will follow your textbook rule. Okay?
Okay, ma'am.
The next case is that of a 55-year-old. So who would like to volunteer for this case? Sanjana is there? Priyanka Agarwal is there? Sanjana?
Yes, ma'am.
Priyanka, you're there?
Yes, ma'am.
Okay, so 55-year-old complained of right-sided ptosis plus double vision. Quite similar to our first, that young patient we saw. Pupils normal, fatigue test positive. Clinically looked like ocular myasthenia gravis. I mean, you see this first picture, there's an exotropia, there is ptosis. And in the second picture, what do you see?
Increase in ptosis.
Sorry, yes, increase in the ptosis, because here you can see the cornea and all. Here your cornea and everything, nothing is visible. So the ptosis will definitely increase. So what will your clinical feeling be?
Ma'am, we will do eye spec test.
Very good. And suppose if I tell you that the eye spec test is negative, then what will you do?
Ma'am, then we will go for serum antibody receptor test.
Correct. Which were the antibodies I told you that you will test for?
Most common, ma'am, anti-acetylcholine receptor antibody test we will do.
Very good. If we did that came negative. So what will you do next?
Ma'am,
Another antibody.
muscle specific kinase antibody.
Excellent.
LPR4 antibody test.
So honestly, in my 15-20 years of my career, I've never tested for the LPR4 antibody. Okay, so I don't know, maybe Vivek can tell me if he's tested or no, but I've never tested. So we did the Musk antibody also, and the Musk antibody is also negative. Now what will you do? But fatigue test is classically positive. So now you tell me, what will you do?
Ma'am, if possible, RNS testing or EMG, if
Superb, you're superb. Yes, you will do an RNS testing and the single fiber muscle EMG, and that's exactly what we did. So we did his I also did the CPK in this case, so the CPK was also negative. We did the acetylcholine receptor antibody test, we did the musk antibody test, both were negative, but that clinical hunch was so strong that this is myasthenia because the fatigability was so strong. So then we went ahead and did the RNS study also, and the RNS study, as you see, was positive. Based on this, the patient was sent to the neurologist. The diagnosis here is that it is a seronegative ocular myasthenia gravis. The patient was started on Distanon, Vizolone, and some calcium supplements, and following which the patient got better. So this was the ptosis that recovered completely, but his EOMs are not fully recovered. So you see, he's able to abduct okay, elevation is okay, but that adduction limitation which was there has not gone. But the ptosis has completely recovered. So he's still undergoing treatment. Okay.
okay,
So the
thank you.
take-home message is that even though your antibody tests were negative, clinically this patient strongly looked like a myasthenia. The RNS was positive. Based on that, the patient was referred to the neurologist, and then the patient was started treatment. So this was a case of seronegative myasthenia gravis. And this is my last case. So maybe we can come back to Indrani. 45-year-old complained of sudden onset ptosis. General health is normal, ocular exam is normal, and she got a CT scan done for this ptosis. So my question to you is, would you also order a CT scan? And if yes, why? If no, why? What is going on in your mind? And you can ask me some more questions related to the examination if you want to.
CT scan was normal, ma'am.
Yeah, CT scan brain was normal. So how will you proceed?
Thyroid testing.
Thyroid, why would you think of thyroid? You're not wrong.
But the
Because
class
a
is
lot
on
of myasthenia-
Myasthenia. So you think in those lines only. Simple.
Extraocular muscle involvement.
Extraocular muscles were normal. Good question. Extraocular muscles were normal. Ask me about the pupils.
Yeah, the
It should be
pupils.
normal, otherwise it is not.
So pupils were also normal. So your differential diagnosis again, you could be that this could be a myasthenia patient, right or wrong?
Yes, ma'am.
Right.
Ask the patient to do the exercises, no, up
Yeah.
and down movement.
And then I was so sure that this is myasthenia, okay? I was biased that this is myasthenia. So see what I found in this patient. If you see very carefully the right eye, I don't know if I was imagining, and you can also imagine with me, do you think that there was a little ptosis? You see that fatigue test I thought was positive, and there was a little flickering in the right lid.
Yes.
Yeah?
Yes, ma'am.
I thought I was very smart. And I thought, array, one more case of myasthenia I have diagnosed based on this flickering. So what is the next thing I do? What will you do?
The antibody testing.
Correct. So that's what I did. I got the antibody test. So antibody was negative. But I have seen so many myasthenia patients that I thought this is another seronegative myasthenia patient. So I went ahead and did the RNS studies also. And the RNS study also was negative. So now what will you do? And the neuroimaging was done, CT scan was done. That was also reported as normal. So what will you do? I've already written here. So because of all this, I said, Arey, something has to be positive. And the patient is saying that, look, my eye was not like that. So showed old photographs. So I said, okay, chalo, let's repeat the MRI because the previous scan that was done was CT scan. So I said, okay, let's repeat the MRI brain with orbit with contrast. So you remember that in all patients, CT scan gives no information at all. The correct choice of investigation is always an MRI brain with orbit. Always use the contrast. So when we did the MRI brain with contrast, what did we find? We find a large tumor here. Why was it not seen here? because no contrast was used. The tumor gelled with the rest of the tissue, so you couldn't identify it. Here you can. So what is the take-home message? In all myasthenia gravis cases where you suspect that the patient has myasthenia, before labeling the patient as seronegative myasthenia gravis, you must neuroimage the patient, and the neuroimaging of choice is MRI and never a CT. Okay? So to summarize, myasthenia gravis can have varying presentations, and history may not always be like what you read in textbooks. Always have a high index of suspicion for myasthenia gravis in all cases who present with acquired ptosis or diplopia, but most important, pupils have to be normal. Pupil involved means that the patient does not have myasthenia. In acquired cases of ptosis or double vision, if your myasthenia workup is negative, then always neuroimage, and the choice of neuroimaging is MRI brain with contrast. Thank you. Thank you, sir. I finished.
Yeah.
Thank you so much, Dr. That was a great presentation.
Rajesh, now take over.
Yes, thank you so much, Dr. Ajit. So just complimenting Dr. Hamalini on her fabulous presentation. I think it is absolutely appropriate for what the trainees need. But at the same time, I must say that, it's a learning experience for all of us as well, because you all get this kind of cases in our clinic. Just to add my two little bits here, as an oculoplasty surgeon, when I get my ptosis cases in my OPD, it's my routine practice to test everyone for fatigability, and I do the ice pack test for everyone. Because, believe you me, I have seen a lot of cases who have been labeled as involutional ptosis, operated on as well, and then eventually, the situation was very difficult and very different because they're proven to be myasthenia gravis when their ptosis is red. And one more thing I would like to add, of course, the panelists are here, but this is what I've felt in my experience is that it's very important to know the technique of doing this very simple clinical test. This tests are simple, but you need to know the technique, which is the fatigability test and the ice pack test, because sometimes you cannot, if you do not do the test properly, you'll get a false negative. That's very rarely a false positive result as well. So training is very important to know the technique of the tests. And lastly, I may say that, I'm slightly wary of doing the neostigmine test in a setup of ophthalmic practice because it can cause cholinergic crisis at times and patients can be in a bit of a trouble medically. But, let's not, deal with that. Let's hear what our esteemed panel have to say. May I start with Dr. Dipankar Das? Dr. Das, we know about your experience in dealing with this kind of cases is quite huge. So I would like you to give two very strong message to our trainees here. Firstly, what will be your most important take-home message from Dr. Saman's talk? And secondly, what will be your message from, the crystallization of your long experience in dealing with this kind of cases to the trainees as well? So what will be your messages to the trainees?
Thank you, Dr. Rajesh. I'd like to congratulate Dr. Hema Malini for presenting such a wonderful presentation for the residents and for all of us. Now, thing is that Hema Malini showed first case, which was a unilateral ptosis, okay? Now, for students, always remember the Marcus Gunn jaw winking phenomenon is one test that you will be doing for the young children or no, because you have to rule out those cases whether jaw winking phenomena is there or not. Secondly, Dr. Hema Malini last case showed a tumor causing a myasthenia-like syndrome. Now think there Eaton-Lampert syndrome, which can simulate a myasthenia gravis. An important thing is that in myasthenia gravis, we know that when you do exercises, the muscle fatigues. But in Eaton-Lampert syndrome, when you do exercises, the muscle strengthened up. Okay, opposite of a myasthenia. Okay, so these two things, because Eaton-Lampert can present, which can have a lower limb involvement or other phenomenon can be a life-threatening condition when you are diagnosis a simulating myasthenia gravis syndrome. These are my 2 points I like to highlight.
Thank you so much, Dr. Das. Dr. Sudhir, thank you for being with us. Again, the same question for you. So what is the most important point you find that Dr. Himalini has made in a very, concise presentation? And what is your experience in dealing with myasthenia gravis, which you'd like to share with us and the trainees, please?
Actually, I was I say thank you to Dr. Himalini. It was a very lucid presentation for all of us. And I congratulate her for this. In my opinion, myasthenia gravis does not follow what she told, what I could gather, that myasthenia gravis pattern does not follow any pattern, specific pattern of ptosis or ocular movement. And this was the main thing which one should think, that this could be a case of myasthenia gravis when it is not following a pattern of ptosis, congenital ptosis, or any nerve palsy. So one must think that this is a case of myasthenia gravis. Along with this, if there is fatigability of lids as well as generalized fatigability, one should also go for thinking about myasthenia gravis. For this, what I suggest, or in my OPD, I do eyes test and muscle twitching test. And apart from that, I ask every patient's attendant that whether this ptosis is variable from morning and evening or after. If it is, it could, if the ptosis is less in morning or when the patient was in rest for overnight, then I suspect that this may be a case of myasthenia gravis also. And if there is a further some history of fatigability after doing some work, then again I go for I suspect myasthenia gravis. And these are the so for this I ask them to take a passport type of photograph by mobile in the morning and after some hours. So if the ptosis increases during this period, I again think that this might be a case of myasthenia gravis. And rest, Dr. Himalini has rightly pointed out every differential diagnosis and test for that. Thank you.
It's a great suggestion, Dr. Sudhir, to, have some kind of photographic record. I think for the patients, it will be a very interesting thing to do, and it will be very helpful for the clinicians as well. Dr. Vivek, we have heard from you as well. So again, if you to summarize Dr. Himalini's presentation in very succinct points, and if you have to tell us about your experience in dealing with this kind of cases, so give us these two, basic points. One is, what do you think is the most important highlight of Dr. Himalini's presentation? And second thing is that what you feel we should know, especially dealing with myasthenia gravis patient, which may have been covered by Dr. Himalini, or she may not have covered it this time.
Yeah. So first of all, thank you so much, Dr. Ajit, for choosing such a wonderful topic, which is useful to every ophthalmologist in their day-to-day practice. And Dr. Himalini, it was a great talk. As usual, there is no surprise at all. So I think, she has brought up a very varied spectrum of ocular myasthenia that can come across in our day-to-day clinic. So if you see the patients with ocular myasthenia, I think we have to be always in the suspicious of myasthenia, because it can masquerade with all type of, the strabismus entity or cranial nerve palsies, or she was mentioning, the supranuclear or gaze palsies. So I think that always at the end of day, when you see and it is not being explained by the routine pattern of clinical presentation, we should think about ocular myasthenia. In terms of test, I think she has rightly elaborated. These are the 4-5 tests that are very much common, easily doable in the ophthalmic setup, and that helps to label that this is an OMG, and then you can diagnose. I think these are the most happy patients, when you treat these patients and they become absolutely normal. So I think this is one of the neuro-ophthalmological disorder where if you diagnose and treat, you can actually make our patients very happy. In terms of treatment, I think we can just for the residents purpose, usually if it is a ptosis alone, you can go ahead with the myastin and get away with improvement. If it is associated with extraocular motility limitation, external ophthalmoplegia, then usually it's good to add on the steroids. So now you can start the steroid in a tapering manner as per the body weight, and that gives you very dramatic response, because the diplopia is very debilitating. So adding a steroid over a period of 6 to 8 weeks, that helps. Sometime what happens, we call it as a recalcitrant OMG. So despite on putting a steroid, as you go taper down, then again the symptoms start reappearing. So in those situations, you can always consider the steroid sparing agent like mycophenolate mofetil or azuran. Consequently, before you completely taper them off, at least a month overlap between the tapering steroid and the steroid sparing agent. So that helps to keep these patients on a remission for a longer duration of time. So that's what I wanted to add. And another group of entities where these do not respond, doesn't ptosis improves, external ophthalmoplegia, status quo. In this group of patient, I usually in my practice try to think about the congenital myasthenic syndromes. So this is one of the entity where you can look for some mutation NOX7 gene. They are very much responsive to the the salbutamol therapy. So you can prescribe them the salbutamol, and they will respond. So this is a rare presentation, but you can keep this in mind. So apart from that, I think she has very nicely covered most of the common clinical case scenario. And imaging, yes, at the end of day, again, imaging is the final call when everything comes negative. Even I would suggest there is no harm in giving the therapeutic trial of gravitar and steroid for 4 to 6 weeks and see whether this does improve if you have a very high index of suspicion for OMG.
Thank you so much, Dr. Vivek. That was very precise, and that was, covered a lot of bases as well. Shall I ask the trainees to please take this opportunity to, think about any questions which might cross your mind. We have the great panelists here. Why don't you go ahead and ask Dr. Samant, Dr. Das, Dr. Vivek, and Dr. Sudhir, whatever you think might be appropriate for you, for your, practice, for your exam, for your training. Just think about something. We still have some time. Any questions you have? There's nothing like a bad question, So please feel free. All questions are very important, and we'll learn from your questions as well, because those questions will make us think. So it's not for you, it's for us. Please go ahead and ask questions. Snehashish, you seem to be very brave. We like your beard. Go ahead. So what is your question, you might think?
Is neuroimaging really necessary even if we get the serological titers high and everything? Is it necessary to go for the neuroimaging, sir? Is it necessary for myasthenia gravis? I know it is necessary for getting other pathologies, but is it necessary for myasthenia gravis?
Yeah, that's how.
Dr. Malini, would you like to take the question,
So,
please?
Snehashish, if my antibody titers are positive, I'm not going to neuroimage the patient. I'm only going to neuroimage the patient when I strongly suspect that the patient has myasthenia. I've done the antibody titers, I've done the RNS test, I've done the single fiber EMG, and everything comes negative. then before I label it as seronegative myasthenia, I will neuroimage.
Who else? Who? Indrani seems to be brave as well. She's got a video on. So Indrani, it's your chance.
Sir, you said key ice pack test and fatigue test. There should be some precautions or the way to do it in the OPD. So, what was your point in that?
Okay. My point is that, especially for ice pack test, you have to ensure that the ice pack is cold enough. Because if you just allow your technician or assistant to get any ice pack from the fridge, you haven't checked it, it might not be cold enough actually. And sometimes, so if you are using that kind of ice pack, you will not really get the result. Secondly, if you have put the ice pack onto the patient and you've forgotten about the patient completely, and the patient is holding the ice pack over his or her eye for about, say, not 3 minutes, not 4 minutes, not about 10 minutes, 15 minutes, then what happens? The cold itself will actually give you a false negative result. So it's very important to ensure the ice pack is actually frozen. And secondly, it do not really go beyond 3, maximum 5 minutes, because otherwise the results are not tenable. Results are not reliable. And fatigability is that you have to ensure that you're looking at the patient when the patient is looking at a focus onto the ceiling, because the patient is actually looking all over the place, then it's not really going to be a very good fatigability, because you need to the answer to your question is in the term fatigability. So you have to make the muscle tired. If you allow the patient to take a little break in between, they may go on for minutes and minutes till actually get the sign. So these are the two things which are very vital.
Thank you, sir.
Who else? Vasavi?
Yes, sir. I have few questions. Like, if there is a coexisting myasthenia.
What is the most important question you have?
If there's a coexisting thyroid and myasthenia, how do we manage? And in cases where there is muscle limitation of ocular movements, how long we will wait and then we will go for strabismus surgery?
So your question's got two parts. One is myasthenia and thyroid combination. And other part was, if you have myasthenia, then you're planning to go for a squint surgery.
How long do we wait till we will keep the person on medication, and how long we'll wait for the diplopia to resolve and to go for strabismus surgery if needed?
Why would you go for a strabismus surgery in a case of myasthenia? Anyway, shall I ask Dr. Dipankar Das to take this question, please?
That's a very interesting question. I also don't have too much because I don't practice thyroid disease. Thing is that if thyroid and myasthenia exist, whether we have to manage the locally, we have to give whatever for dry eye and other thing we have to give, and also anti-thyroid medication as well as the corticosteroid, which works both in thyroid as well as in myasthenia. Remember one thing, myasthenia is an autoimmune disease, okay? And thyroid is also an autoimmune disease. So whatever corticosteroid you are using, along with azathioprine, or a better medication, it will be a biologics, which is a rituximab, okay? There are newer biologics which has been tried for thyroid eye disease as well as myasthenia, okay? So these are, and some of the biologics are coming in the clinical trials for this disease. So we have to wait sometimes, and one therapy, whether it can give a local effect, is the role of botulinum toxin. Okay, whether local botulinum toxin somehow will help locally. It's not a systemic way it will affect, but local muscle, whether it will affect, I don't have an answer, but someone may practice this. We have to have a time till we observe the thing and see the response. Thereafter, maybe some sort of improvement will be there both for the thyroid and myasthenia with the medical treatment. Okay, and thereafter, if it is not improved, then maybe we take a surgery in those cases.
Yeah, can I take Vasavi's question? We do see
Sure, of course.
Yeah, we do see, both the scenarios what she has asked about. So, in fact, in a known thyroid patient, if there is a ptosis, we should suspect that there is the OMG. Okay, so in those patients, you would rather subject for, the test what we have learned today. And if you get, the serum antibody positive, then as Dr. Dipankar said, both of them, they are an autoimmune diseases, right? So you can take care of treatment as a standard protocol for either of them. You would get a good result. As far as strabismus surgery and OMG, I have done couple of patients, where they are long-standing OMG with extraocular muscle involvement. They are, they are kind of recalcitrant. They don't respond to even high dose steroid, 2 to 3 episodes of giving, this steroid therapy on immunosuppressant. They don't respond. So at the end of day, the patients, if you want to make the patient's life better, they are like very large exo, hyper. Depending upon that, you can take a call for doing strabismus surgery. So in OMG, we can't give them a straight, the aligned eyes, but you can reduce, the angle of deviation to bring them into a range where you can help them to fuse with the help of, add-on prisms, or to improve their field of single binocular vision.
Vic, what is the rate of false positive antibody test with OMG and thyroid?
False positive test, I would say almost 20 to 30% of the patients, they would have false positive test. But they are very distinct, because see, anything drooping down, that we always suspect on oculoplasty point of view, there is something gross in the orbit, right? Because in a known thyroid or a proptose or a thyroid patient, if something drooping down, so one would image, and if that is normal, then your antenna is raised. Okay, am I dealing with OMG? There is nothing in the orbit or a brain.
Absolutely, because they go hand in hand quite a few times.
Yeah.
So, anyone else? We have still
And if
some
you
time left.
see in Himalini's last case, if the antibodies are positive, will she stop without doing a neuroimaging? See, it is luckily it was negative, so you did the neuroimaging and you got the special.
Yeah. Correct.
What would have happened otherwise?
Correct. You're absolutely right. So there is something called as a clinical, sixth sense that you do, that is always there.
Yeah.
I have a question to everybody here. If you come across a patient with myasthenia gravis and you have to do a cataract surgery for that patient, what precautions will you all generally take? What is your choice of anesthesia?
So, question goes to Dr. Subodhi.
You're not This is good. He's silent all the time. He should answer this.
And normally we do the topical anesthesia, so I don't think there will be any problem with this here. Am I right?
Correct.
Yeah.
I would choose topical anesthesia. Anybody else?
Anyhow, topical anesthesia is better. Yeah. And intraocular, there is no involvement, so should be all right.
No,
Is he right, Dr. Himalini? Is Dr. Subodhi right?
He is right, but it's not that you
But-
can't use, you can't give a periocular injection, but the choice, a preferred choice is a topical, to do the surgery under topical anesthesia. But then what happens to those surgeons who are not able to perform the cataract surgery under topical anesthesia? I don't think a peribulbar block is contraindicated. What do you say, Vivek?
Yeah, so I was just about to come. Those who don't do under topical, I think if it is a known OMG patient, we have to make sure that the patient is under complete remission. Number one. Number two, you have to counsel also that, sometimes they attribute that because of, the cataract surgery, my symptoms got worsened or something like that. So I think that counseling is also very, very important. And there are very anecdotal reports when the patient had given the block for cataract surgery and that has triggered the ocular myasthenia. So I think that counseling is also very, very important. So lignocaine toxicity has been a trigger for ocular myasthenia. So we should
Yeah,
be counseling
means
patients
the
accordingly.
NMJ can get worsened.
Yes.
Here I like to add one thing. This topic which not been addressed is that drug toxicity which lead to myasthenia. Okay, penicillamine is
That
one
is
of
another
the
big one.
aminoglycosides. Okay, antibiotics. No, that can induce myasthenia. So in history, always these things has to be find out if there is a drug toxicity in those situations.
Absolutely. You hit the nail on the head completely. I think it was a very fruitful discussion, all in all, and I think it was very informative. Dr. Himalini, thank you so much. Dr.
Thank you,
Vivek,
sir.
Dr. Das, Dr. Sudhir.
Dr. Rajesh, I have a
Yes,
question.
go on.
Achha, suppose if you don't treat this patient of ocular myasthenia, does it lead to systemic myasthenia?
It
Yes.
does.
It is a progressive disease, sir.
40% of the patients progress to generalized myasthenia gravis.
So is it the ocular sign, the first sign of myasthenia?
Sometimes they present ocular with ocular signs. Sometimes a generalized patient may go into ocular.
Yes.
Has the role of thymectomy in these cases, ocular myasthenia cases?
Very important.
Yeah,
If you find that's why CT scan is done for all the patients.
No, but if it is tumor is not there, then what? Thymoma is not there.
Then only if you find an enlarged thymus gland, then you would do a thymectomy.
Otherwise, not.
Otherwise,
So
no.
we need to define that before.
Yeah.
Yes,
Enlarged
absolutely.
thymus gland.
I just wanted to add regarding, the thymectomy. So we had recently a clinic with Dr. Umapathy from SNEC Singapore. So he is a very renowned neurologist, and we had kept few cases with, with and without thymectomy. So if you read the literature, I think those patients who has a known thymic hyperplasia or so-called thymoma, there is a direct indication. However, if you read the literature, there is a subset where there is no thymoma, but these patients, they are like recurrence, they are recalcitrant, they don't respond. Then those patients also, if you do a normal thymectomy, that reduce the dependency on the long-term steroid or the acetylcholine receptor inhibitors. So yes, in both the situations, thymectomy has been suggested. The only thing is now, as the treatment modalities, they are becoming more advanced. It has becoming the routine practice in Western world, like robotic approach or the minimally invasive thyroscopic resection of the thymus. So they are helping more and more because in those patients who start this disease in early childhood, it's very difficult to put them on steroid for a long duration for obvious reasons.
I think it's a very important point which Dr. Vivek has made, and probably for the trainees, it's more of a distinction marks kind of question. However, I think we are all standing at the cusp of a very important, turning point in the medical treatment progression, because immunotherapy is becoming so prevalent and so important in most of our fields. Thinking about all these, autoimmune disorders, cancer, and whatnot. So I think it's very vital. We have to keep that in mind. So, as I said, it was a great session we had today, very informative and thankfully very interactive. We learned a lot. So may I pass on the baton now to Dr. Subudhi?
We have one more, I think, panelist is here. I think is that Dr. Rahul? Dr. Rahul Prasad, are you there?
Turn off hai, photo turn off hai, video and audio.
Yeah.
His
Rahul
system is on, but he's not there, I think.
Not there, I believe. Anyhow, so it's okay. Let me offer the vote of thanks. So I thank Dr. Himalini. It's really wonderful talk today and very precise. I would say very precise from the postgraduate's point of view. definitely the point wise they will remember very well whatever you
Yeah,
said.
yeah. And the main thing is that the way she asked the questions is very, very nice,
yes,
Malini.
that's-
I really appreciate because you stopped for them to answer. That's
Thank
the
you so
way we need to teach them. Let them
Yes.
come out.
Yes, she has
with
introduced
the
one thing
suggestion.
also,
That
putting
is
a
very,
number,
very important.
name of the resident and ask her to or him to answer the questions. That is a really wonderful thing. It's a good thing. So that the students they get involved. Thank you very much for involving the students one by one. So
Thank you.
wonderful discussion, and Dr. Rajesh also. I thank Dr. Rajesh moderating very well, bringing out the key points from the panelists and from the students also. Everybody has contributed to this. Everybody's contributed this. This discussion, and I thank the all the panelists and also our residents coming.
And
Open up.
particularly Vivek, you say thanks to Vivek.
Yes,
He contributed a lot. We should thank him also. Dipankar contributed very specifically.
It's always a pleasure, and like I heard Dr. Himalini is talking, so I just jumped in.
Liar, liar, Vivek.
Nah, he's a liar, no? Big liar.
Liar, liar, pants on fire.
And we should say thanks to Dipankar also and Sudhir.
Thank you, sir. Thank you.
Yeah.
Thank you, sir.
Pleasure.
One thing I'll tell you,